on behalf of Gesundheit Österreich, which is the Austrian National Public Health Institute. I would like to welcome you to this session, the session on people, planet, health, co-benefits through health promotion. My name is Caroline Kostongs, and I'm the director of EuroHealthNet, which is a European partnership of national public health institutes, regional authorities, and we are concerned about improving health and reducing health inequalities and taking forward well-being. And I'm delighted to have this excellent panel here and a keynote speaker and our colleague from the Austrian Federal Ministry of Social Affairs, Health, Care and Consumer Protection. Your department head, Judith Delegrazie, and you would like to address the audience with some welcome words. The floor is yours.
Hello everybody, dear participants. I welcome you all very warmly to this session. It is organized within the framework of the Austrian Agenda Health Promotion. Agenda Health Promotion is the name of the focus that the Austrian Federal Ministry of Health currently puts on health promotion. And within this focus, in spring 22, we founded 3 competence centers at our National Public Health Institute with the aim to strengthen well-being and quality of life in the long term. Let me give you now some information on these competence centers because they are the ones that inspired the content of this session. When we started the Agenda Health Promotion, first of all, we had a very strong political will to address the challenges of the climate change concerning population health as well as the healthcare system. Therefore, the so-called Competence Center Climate and Health was the first to be founded. What does this Competence Center do? It develops strategies and measures to reduce the CO2 emissions. For example, recently we've started offering consultations to healthcare institutions like hospitals, pharmacies, primary healthcare units on how to reduce their CO2 emissions, and there's a very high demand for these consultations, so they seem to become a success. The Competence Center also addresses the direct and indirect consequences of climate change on both population health and the health sectors, and we want to strengthen the climate resilience and climate adaptation potential of the health sector and the population. Last but not least, the Competence Center is focusing on the synergies between health promotion and climate change mitigation. The second competence center we founded is called Health Promotion and Healthcare Systems. Why did we need this one? Basically because the reorientation of the healthcare system that was already recommended in the Ottawa Charter still hasn't happened, or at least it hasn't happened in the extent that it should have, and there still is lots of work to be done in this area. So the Competence Center supports the actors in the healthcare system in ensuring fair access to the healthcare system, in the appropriate implementation of both health promotion and health literacy in healthcare institutions, and in the implementation of person and health-centered healthcare. At that point, after deciding on the first 2 competence centers that I talked to you about, we had a very strong feeling that we needed something more, because even though the benefits of health promotion are well known, the funding and the implementation are still frugal, and there still lies high potential in health promotion. So what we wanted was a competence center that focused on really pushing health promotion a huge step forward, and we had ideas like capacity building and innovation on our mind, and so the so-called Future Health Promotion Competence Center was finally founded. It is located at the Healthy Austrian Fund, and it builds on the expertise and the long-term commitment of the Healthy Austria Fund to promoting health, quality of life and well-being for all people in Austria. What does it do? It strengthens health promotion and primary prevention by advocating for the further development of the knowledge base in health promotion and of capacities in research, practice, and policy. It promotes and supports the international as well as the national exchange on health promotion, just as we do today here in this session, and it pilots and it embeds the innovative health promotion measures. The Future Health Promotion Competence Center also is the one that had the lead in organizing this session here. So thank you very much to Gerlinda and to Petra for all the effort that you put into it. With the Agenda Health Promotion, we want to look beyond our own horizons, and we also want to jointly develop long-term future perspectives for health promotion. So against this background, this session is intended to support the further development of 3 fields of actions, and these 3 fields of actions are also the core working areas of the 3 competence centers that I've just introduced to you. Community health promotion in the healthcare system, and climate action and health co-benefits. I'm looking forward to interesting new perspectives, to a stimulating discussion. I hope you'll all enjoy these sessions, and thank you very much for joining us.
Thanks a lot, Judith. It's really inspiring, I think, and a great example that Austria is setting with your agenda, health promotion, and with the setting up of these 3 competency centers. When I listen to the themes of the competency centers, I think there are several common themes that we will be discussing with the panel here. One is obviously working together across sectors. How can we do that better? One is about health promotion. How do we see health promotion developed in health systems, and generally, how can we boost the health promotion profession? And indeed, do we have sufficient capacity in place, human resources, financial resources, in order to implement it all? Before we start with the debate, I would like to give the floor to Professor Ilona Kickbusch. She is instrumental in health promotion. As you all know, you were at the very start of the Geneva Charter back in the 80s, and we would like you to share with us what are sort of the learnings in the past decades, what are the failures, what went well, and what can be taken forward for the future in terms of governance for health promotion. The floor is yours, Ilona.
Yes, thanks a lot, Carolyn, and maybe you should have taken a picture from me in 1986, and then we could have had a discussion about healthy aging or something like that. But anyhow, I'm absolutely delighted to be here, particularly because in my career, both at WHO and afterwards, I have been able to work together with Austria in general, with the ministry, with some of the organizations that were founded to strengthen health promotion, and also with the city of Vienna. And first of all, I would like to congratulate Austria for keeping this flame alive, because health promotion was not always popular. And it's quite a feat to have done that. And maybe that's also a subject for the panel to some extent. You know, what are these sort of flows of up and down? And how can a concept that's 35 years old now still be so alive? I'm actually quite interested here in this audience, who was born after 1986? There you go. You didn't even exist when the Ottawa Charter was founded, but I still hope you know it by heart, because those 5 action areas have actually gotten to be stronger and stronger. And we know from health research in many different ways that what was brought together in the Charter, even though sometimes we now use different words, has been central. And we also learned that during the COVID pandemic. We learned that we need different types of policies that support health in many different sectors, obviously. We learned that the community is absolutely essential. We learned that health literacy is critical and crucial. We learned that supportive environments are, again, absolutely central to being able to manage a pandemic, both the social and the built environment, if you think of shutdowns and everything. And we learned that, this area, this weakest area that you already referred to, health promotion in the healthcare system, failed us to a large extent during the COVID pandemic. And therefore, the starting point, and I had a conversation with Rüdiger earlier today, is to say, gosh, we have all this knowledge, we have all this experience. If you listen to what people say are our problems now, how do we reach the community? My gosh, health promotion's been doing that for 35 years. But to some extent, we weren't asked. And so I think here is something also where we have to learn while we move forward, and I'll come to that moving forward in a minute, but the compilation of this enormous knowledge that exists and the difference it has made and can make is absolutely essential. And the good news is that also in WHO, where health promotion has sort of moved like this, it's up there. Rüdiger will talk more about it afterwards, but I want to underline that in the new strategy of the World Health Organization, health promotion, the promotion of health, is the first priority. And it says, and I'll quote that because that is the part of health promotion we ourselves have sometimes also not underlined and pushed enough. It says, promoting health by addressing the root causes of disease and creating conditions for good health and well-being. And what we said in the Charter, a bit poetically, health is created where people live, love, work, and play. Everyone attacked us because of the word love. You have caring communities here. The Charter was adopted in '86. That's when the AIDS pandemic started. That's where love impacts health. And I think that visionary thinking, and to some extent, if I might say, that courage that the community that pushed health promotion in 1986, my God, were we attacked from all quarters, is something that we, to some extent, also need to reintroduce, perhaps. We maybe in health promotion need to become a bit more controversial again. And I think particularly in this notion of a perma-crisis and what is needed to move forward, and this understanding, and we now have a word for it, and I'm so thankful to WHO and Rüdiger. We said health is created in everyday life. And where people live, love, work, and play. Now we say, where they shop, where they Google, where they do all these other things, where they travel. But the thing is, how can you grasp that in one term? And at the 10th conference with the Geneva Charter, and I hope 35 years later, one of you will give a talk and ask the audience, where were you in 2021? The Geneva Charter says, the health promotion of the 21st century is to contribute to creating the well-being society. And this, I think, must be the vision and the goal that we have. My second point is that, of course, health promotion, and if we think about the discussion on the perma-crises here, from the start said we need the policies of other sectors, we need to work together, we need to invest for health. And I think some of the discussion here at the forum has gone in slightly the wrong direction. It keeps saying invest in health. No, invest for health. And of course, invest in a way that the well-being society overall benefits, and not just health. so that you have a caring community, and we know that people who can care in good conditions also benefit for their health. Social support. If you lack social support, it's as bad as if you were smoking 20 cigarettes a day. So I think, those kind of things are things we need to consider about when we say invest for health, which areas do we think about? And that, of course, the health system deals with the consequences of political decisions that have not been made. Political decisions that have not been made about food, about traffic, about the environment, and all of that. And I think also we should probably be more explicit about that. And for me, a European health union is exactly about that. The European Union has the possibility to be one of the greatest regulators for health in its present competencies. And this is something I think we health promoters must also fight for. Two more issues before I end. One that we can think that we from health promotion can also bring to the dealing with perma-crises is that we were never simplistic. We always said health is a pattern. We always said health is a problem, a process, And therefore, we always started out from this notion that in political science we call wicked problems. Problems that are generated in society and that need a broader approach to address them, where one approach alone is not sufficient. And that's what we learned during COVID. One thing is not sufficient. We need to deal with wicked problems. We need to deal with constantly changing environments, complexity, uncertainty. And this is something that health promotion can bring to health policy in a new way that we have not done before. And that's so essential if we want to build trust in societies. So my fourth point is related to the competence centers. And I think health promotion now has the opportunity to contribute to several major paradigm shifts, and I think it benefits from these paradigm shifts with new energy. I'll just name them because you'll be discussing them afterwards. The digital transformation of society, the importance of resilience of systems and communities and individuals. Think back to Antonovsky. The One Health and the planetary approach, the coming together of infectious and non-infectious diseases in joint strategies. All this is stuff that health promotion can work on and can contribute to. And I think these competence centers give an opportunity. And of course, you've just discussed the new economic thinking around that. What is the economy of a well-being society? What is the goal of an economy? And remember, the health economy, particularly if you were to combine all of the economy that is detrimental to health and the enormous economy that the health system, with everything that is linked to it, constitutes, is a major part of our society. And therefore, really understanding the economy of well-being and who profits now from ill health and who should profit from health is one of the central questions I think we need to answer in health promotion. So basically what I'm saying is, if we talk about the well-being society, this is a new social contract for health. This is a social contract for health that is built on investing for health. And that, to me, is the goal of health promotion in the next 10 years. Thank you.
Excellent, Ilona, investing for health and rethinking our economies and the many other important items that you mentioned, which we'll be taking up in the discussion later in the session. Before we start with the panelists, I would like to indeed remind you that there is this Slido with the hashtag Moon that you can use to insert your questions, in particular for the online participants. But I would really like to get you in live, let's say, so you can also save your questions for the debate later. Our Jonker Steiner Torgin, Isa, will monitor all of the Slido questions. So thanks, Torgin. I will get back to you. And we will also hear from Ilona later at the end of the session to reflect on the debate and what has been said. So let's now go to our first panelist, Professor Margaret Berry. She is a key figure in the health promotion scene as well. She's Professor of Health Promotion and Public Health of the University of Galway, and she's also the head of the WHO Collaborating Center for Health Promotion Research. And you will look at this very much from the mental health perspective, no? And to see, okay, what are our challenges in terms of economic and policy structures and in terms of our capacities for health promotion in terms of implementation. Margaret, the floor is yours.
Thank you very much, Caroline. I think I was also asked to look at the challenge regarding evidence-based actions, actually, as well. So I'll do what I'm told, and I'll try and address all of that. As we've already heard, I mean, there is a considerable base of knowledge built up now regarding, cost-effective, affordable health promotion actions, but the implementation is very fragmented, and in most countries it is not at a scale or scope that's going to make a critical difference at a population level. So I think, in fact, one of our key challenges is scaling up and integrating evidence-based health promotion actions into mainstream delivery in a sustainable manner. So looking to the future in terms of that. And I think one of the issues here is that health promotion is still poorly understood at a policy level. Yeah, the evidence is there, but what does it look like in practice? And I think that is we need to have much more effective advocacy around health promotion. This is particularly the case when we come to mental health. In the area of mental health, the discourse, the budget, the policies are still very dominated by a focus on illness and by individual-oriented treatment. Over 20 years ago, WHO clearly stated we need a population approach to promoting mental health and well-being that brings a focus on promotion and prevention alongside treatment and recovery. And that was driven off the realization that treatment approaches on their own are not enough. It is interesting to see that in the 2022 annual report, it states that the mental health budgets globally, 2/3 of the budgets are allocated to psychiatric hospitals. Now, that is not going to bring about changes at a population level that will promote mental health and well-being. And this was made clear during the pandemic, that we need to respond in new ways to population needs. There needs to be both universal and targeted actions to enable people to support and enhance their mental health and well-being. And I suppose this is where adopting a health promotion approach comes in and has many benefits, because we've seen the area of mental health promotion develop to bring the theory and the evidence regarding how we can strengthen protective factors for positive mental health and well-being, and how we can enable access to skills, to resources, and to supportive environments that will enable more equitable mental health outcomes, and to do that at a population level. So strategies have been developed that can address the determinants of mental health, and we know from the evidence the most effective ones adopt a life course approach, and they adopt a settings approach. Over the last 30 years, quite a lot of evidence has been compiled, so we have good information about what works in terms of lasting benefits, and also in terms of the co-benefits. When we promote mental health and well-being, it has benefits for physical health, for social functioning, for improved performance in terms of education and employment, and for general well-being. So there's a good case here, and there's a good social return on investment in this area. So we need to look and see how we can scale it up and do that in a way that will really make a critical difference. I think for that to happen, we need enabling policy structures that really give a mandate for cross-sectoral actions and for universal actions, so for departments to work together, to put in place the policy processes and structures that will enable effective working across departments, so that when they come together, there's a framing of the issue in terms of what speaks to their own policy priorities, and also that there are accountability mechanisms. But also, and I should have said that the co-benefits are clearly articulated, because when people from social protection come round the table, like, well, what has mental health got to do with me? How can our department contribute? So that needs to be made much more explicit. I think there's also a need for a much greater focus on effective implementation systems. And we know this from the implementation research that has been done. Looking at organisational capacity to deliver evidence-based actions at the national, but also at the local level, to ensure that the structures are there so that effective actions can be embedded into mainstream delivery. And finally, I think we need to see the workforce with the right mix of skills to work in partnership across sectors to make all of this real and to really facilitate that effective action. So just to finish, just coming to the community setting, which I know this session is focusing on, we have many examples of innovative community strategies that look at promoting mental health through, for example, strengthening social connection, through community empowerment programs, through working in partnership across different sectors. And they seek to kind of create social cohesion, building trust, and establishing social connectedness, community development approaches. But also addressing social issues of isolation, of the quality of the living environments, working with local councils to do that. I want to look at one example that is being scaled up, and this is the example of social prescribing. It's been scaled up in my own country, in Ireland, by the Health Service in cooperation with community and voluntary sector. It's also been scaled up in the UK through the NHS. I mean, social prescribing is essentially where people are linked in with sources of community support. It's called non-medical referrals, really. So people can access the resources that they need. So it could be participation in creative arts, participation in education and lifelong learning. It could be peer support. It could be just connecting with people. We've heard earlier this morning about men's sheds, community actions, and these strategies. And I'm interested to see how this scaling up happened. Essentially, there was a commitment in terms of the programme of government to roll this out. Long-term funding was put in place to resource it. We saw there was buy-in from local structures. So all of that planning work was put in place. So we had primary care working very closely with the community and voluntary sector. And there was investment in the staffing. So we had link workers put in place to make sure this actions. So, and also there was a commitment to building up the evidence regarding both the outcomes, but also the implementation. So this is an example, I think, of what is needed if we really want to see investment in scaling up effective evidence-based approaches.
Thanks a lot, Margaret. I'm happy that you brought up social prescribing as an innovative example. I think there's a lot of potential there to further explore and get the data and the evidence to what extent it works. Thanks also to bringing in the evidence base that's out there. We know what works. The return on the investment, I think that's an area where we may need more evidence, and I would like to bring that in the discussion later. Indeed, working across sectors. So thanks for that. Keep your questions for the Slido or for later. I now would like to move to Djoeke van Dalen. Djoeke van Dalen is also a person working in health promotion for many, many years. She is now the senior advisor at the National Institute for Public Health and the Environment in the Netherlands. And you have a lot of experience with practice. So how at the community level sectors and stakeholders work together, and what are the challenges and the barriers, and what can we learn after so many years of looking at how people are working together, and in particular for this triple win that what health promotion wants to achieve, and what Ilona also mentioned for health, for social inclusion, but also for environmental issues and climate. Djoeke.
Thank Thank you very much, Caroline. And thank you all for sitting here and telling you more about the enablers and the barriers of intersectoral collaboration. Excuse me for my voice, but I make it too late because personal relationships are very important, so I make it very late. But it's okay, I think. Well, the first enabler, I do think you know all these enablers and also know the barriers I will mention. I hope, because you are doing it right. But we know a lot about the enablers and we know a lot about the barriers. But, well, we have to make more steps forward. But first I will mention some enablers. And the first enabler, you know all, is a shared vision of the problem to be addressed and the successes of the collaboration. It contributes to the commitment of your partners to have a shared vision. And it has to be a long-term vision. And maybe the vision of well-being can help us. Well, the second is at the start. The second enabler is at the start of a collaboration. Start with connecting with existing collaborations. Because we have not so much time, and in practice we have not so much time. Do connect with existing networks. A third is the communication, and it is about regular updates of just the progress and the success of the collaboration. And that is very important for the visibility of the collaboration, because that is very important enabler also to be visible in the community, your collaboration. And it keeps also your partners engaged, the communication. And related to that, I mentioned it already, is the personal relationship. They are very important in the collaboration here on all levels. And for that you need, in all communities practice we heard, you need to have face-to-face meetings. I'm sorry for the online persons, but it's better to be in person for the collaboration. You feel that you can trust on each other and you can rely on each other. So online is very good, but do also do some face-to-face meeting. The fifth is the win-win situation, the win-win for all parties in the collaboration. There has to be mutual benefits for every partner in the collaboration. And I want to mention one example of the triple win solution is, for example, a small community practice. It was a food garden. It was located in the deprived area, and they produced fruit and vegetables ecological. But they had also people from within distance of the job market volunteering in the garden, and the fruits and the vegetables was for the food bank. This is a triple win situation. Every partner can win something, had an added value. So it's a very well. I have heard it already. Support in policy, support in structural processes is so important. We know that for years, from 1986, I'm not sure. But it's still difficult. Well, we can use the SDG. And this morning I heard an example of the Ministry of Slovenia. Hey, you have to connect with existing policies to get support for your sustainability of your collaboration. And I heard the Minister of Slovenia say we had problems with the brief alcohol intervention, and we connected it with the employment policy. So she connected with important policy. So that is very important. I hope you heard me, because I forgot the microphone. The last one, but not the last one in ever, but for this is very important, is effective leadership. I have heard it all more times here in the conference. An effective leader is capable to keep trust and to keep a good relationship. And it is mostly a champion, a dedicated person with project and good management skills. There are also barriers, and often the barriers are the opposite of the enablers. But we know all the barriers. I think they are very known. I hope not too known, but lack of budget, lack of time to work on the collaboration, and lack of qualified staff or personnel. Well, you can't, if you have no time, you can't work on good relationship, and you can't work on understanding each other language. So that is what we need. Other sectors speak another language, we know that, but we have to invest in that language and to understand each other. And the last barrier is, I have 1 minute, less than 1 minute, is very important, I think, in all countries, the troubles of the difficulties in the public administration, in the difficulties in legislation. We're working in silos, and that hinders the intersectoral collaboration. And I will stop now, but I want to share in the discussion an example. In the Netherlands, we are going to make a step forwards in more intersectoral collaboration by making a little change in our system. Well.
Oh, but now we want to know.
No, I wanted to tell, don't want to tell because I am too late.
Oh, okay. Oh, all right.
I want to share
nice
it, but
cliffhanger.
It's a cliffhanger. Okay.
It is a cliffhanger.
Yes.
Okay, it's a cliffhanger.
So you need to understand it.
Yes, I'll go back to you. So thanks for the enablers and the barriers. I was thinking when listening to you with your enablers, like, you know, the personal connections and talk to the people you know and sharing vision. You know, is that not a little bit too small? I mean, do we get more the drastic change that is needed if we move, you know, with too small steps? And how can we overcome that? And that the public administration is so rigid indeed that doesn't allow people to do things very differently is important to mention. And you mentioned, like what you mentioned also, we need a workforce across sectors. And that's what you mentioned as well. We need qualified staff to work across sectors. I mean, does this mean new professions, or are the consequences for education? For the discussion. Now I would like to move to climate, because for health promotion it is increasingly important to work with the environmental sector and on climate change. And Miriam Privarova, you are a Youth for Climate delegate at the World Bank. And my question to you is whether climate and health, indeed, how can you work better together, more efficiently? And what do you expect from the health sector? And what sort of participatory approaches can help here? So, Miriam, floor is yours.
Yeah. Thank you very much for the invitation to speak at the European Health Forum guests, and in particular this panel. So, as a Youth for Climate delegate and young development professional, I'm convinced that inclusive and community-level action must be at the cornerstone of our efforts to fight climate change. I can see it firsthand within the Youth for Climate community. You know, it is the young people who feel empowered, who then actually take the action in their local communities. And for many of the young people, a strong motivator for being interested in the environment was being part of an activity or a group on a topic they cared about. You know, there are many great initiatives all around the world, started and led by youth, such as Sabji Cooler in India, which is basically a portable zero-energy cooling chamber that keeps vegetables fresh for 5 days without energy input. Or there is another one, such as Tree Square in the Philippines, that is a scalable model for urban reforestation through collective and individual action to regreen cities. So I really think that it is the local action that is the best suited to integrate health and climate outcomes and maximize positive externalities of climate action for health, because it has an inherent legitimacy with local people, and is well placed to facilitate adaptation to specific consequences of climate change to every local area. And community level action also allows for climate innovation to be tested within the local area. And it is often young people who, through empowerment and participation, come up with and spearhead innovative and bold actions on climate adaptation, mitigation, and resilience. And actually, empowerment and participation are two important concepts in climate action as well as health promotion. So I think there is no need to repeat that climate change is a public health issue. And the WHO recognized climate change as being greatest threat to human health in the 21st century. And we, within the Youth for Climate, in our last year manifesto that was part of the pre-COP and COP processes, we recognized that human and planetary health are interconnected. The policies that need to be implemented to reduce greenhouse gas emissions will bring substantial benefits in heart disease, diabetes, obesity, road deaths and injuries, and air pollution. And the health benefits arise because climate change policies necessarily impact on two of the most important determinants of health, which are human nutrition and human movement. And evidence indicates that these co-benefits will result in a substantial reduction in the cost of healthcare in many countries, with a potential for very large gains for national economies. So, given that health and climate have so much potential there to be working together, how come this link is still not sufficiently made use of? I think that we can all agree that the climate health nexus is increasingly getting attention, but we are still not there. And the UN Climate Change Conference of last year, the COP26, actually put little focus on health-related goals. And similarly, health is often disregarded in the national determined contributions, national climate policies. But on the other hand, I must say that I noticed that last year, over 350 organizations representing over 40 million health professionals wrote a letter to G20 leaders stating that a truly healthy recovery from COVID-19 crisis means acting to prevent climate change. And I totally subscribe to that. So basically, how can we foster stronger collaboration between climate action and health promotion? The good news is, when health voices speak, public listens. The medical community is highly trusted, much more than governments and politicians where most people hear about climate change. So please, we have to make more use of that. And on the other hand, giving our increasingly heard voice in the international climate change arena, young activists' role in incorporating climate and health perspectives can entail including climate change effects on health into messaging around planet-friendly behaviors. Then also enhancing the nexus between well-being and nature and community-level action local projects. And also, our role is to also push for more focus on health-related goals within the national climate policies and climate pledges. I really think that the climate action is our biggest opportunity for better health and well-being. Thank you.
Thanks a lot, Miriam, for your passionate speech, so important. And I do think young people, they have the power to make a change at the top government level, as what we have seen very much before COVID, the youth strike, Youth for School strike, and so on. And I also think that young people bring up a lot of innovation, innovative thinking, that is important for us to take up. I think health promotion, health promoters have an important role here to translate the climate goals to the health sector goals, because indeed not all stakeholders in the health systems are on board on the climate challenge, and health promoters have an important role to go from climate to the healthcare and the doctors and the nurses and so on. So let's now move from the climate and environmental objectives to social objectives, social inclusion and social equity, and how we can care much better of each other at the local level. I'm very happy to introduce to you Klaus Weck-Leitner. You are working for Verein Sorgenitz. It's an NGO based in Vienna, and you are representing the caring communities, which I think is a great concept, the caring communities. It hasn't yet trickled down in the European Union bubble, and I'm looking forward to hear to you what you have to say. Klaus.
Yes, thank you very much for this very friendly introduction and for having me here. Thank you to the organizers to be on this panel with these wonderful, experienced colleagues. Thank you very much. So I'll do this brief statement in 3 steps. First, I would like briefly describe what we're doing as Association Care Web, literally a Verein Sorgenitz. Second, like to highlight one specific caring community initiative in Vienna, and third, what we have learned so far. So first, as an association, Sorgenitz Care Web, we're a very small NGO situated in Vienna, which as a kind of network organization has the goal to open societal spaces and settings which enable citizens, carers out from the informal and formal care sector, organizations, politicians, academics, artists, and many other actors to relate to each other in a new way in order to change social care cultures and care structures. So we are involved in very concrete caring community initiatives and also in international caring and compassionate community knowledge networks, and therefore also in the critical reflection of current societal developments in the care sector. As for example, last week with the organization of an international symposium on care and justice in Vienna. Second little highlighting on the project Achtsame Achte in Vienna. So in Vienna's Josefstadt, which is in the 8th district, since 2019, we're implementing the caring community project literally called Achtsame Achte, which means mindful, attentive, or caring 8th district, and it's funded by the Austrian Healthy Fund. In the framework of these projects, my colleagues, Daniela Martusch and Gerd Dressel, have been facilitating, enabling the strengthening of everyday solidarities in the neighborhood, of intergenerational relationships, of local care networks between informal and formal caregivers, and of new networks between, I would say, classic care contexts or health contexts and arts, museums, culture, businesses, and civil society initiatives. And they are also creating forms of appreciating the life experiences of older people and caregivers through storytelling approaches. So this caring community project is very much about strengthening social participation, social capital, building agency, as well as health literacy and the co-creation of new local specific care works. Third point, what have we learned so far? So there is very high societal willingness to engage in community initiatives, but still, as we heard, a lot of need to develop more creative and locally specific forms of smart intersectional networks and governance structures. So it's not to exploit volunteer engagement or to misuse it as gap filler to solve this so-called care crisis. Second, caring communities are complex, socio-ethical, cultural, and structural, unpredictable development processes that are subject to their own very specific temporalities. So conventional project and funding logics therefore tend to fall short, temporally, economically, and also evolutively. 2 more points. We see one danger, one risk that caring communities unintentionally contribute to a form of, Silke van Dijk and Dine Haumler call it community capitalism, namely that the unresolved political structural care challenges, especially those triggered by capitalist economic system, are parked in the communities, in the private, and perpetuate care inequalities. And last, I'm therefore not a great friend of the concept of resilience and resilient communities, because resilience, from my point of view, essentially is a conservative, neoliberal concept that seduces people into creatively creating ways of dealing with difficult care challenges within an existing inadequate health policy framework. So I have more sympathy for the understanding of caring communities as transformative communities that are in correlation with other social transformation movements in the areas of environmental and climate protection, the common good economy, or the democratization of work. And precisely for this purpose, care policy as well as health promotion needs to be anchored in all policy areas, and appropriate forms of care governance need to be established. So health promotion can and should play a central role here, but not in the sense of optimizing consisting health systems, rather in the sense of the support for transforming systems, as well as ways of life and care towards caring and sustainable and maybe more loveful societies.
Thank you, Klaus, for introducing this new concept of caring communities, which has a lot of potential, I think, in what we try to achieve here. It's not about exploiting the resources that the community have, so that they have to solve all of the health problems and so on, but it's also about proper resourcing of community care structures. And I think it's very much linked to health promotion, as you are saying. So it is a promising concept, and I would suggest for the competency centers a topic to indeed dive into and more on how this can help us. It is also relevant very much to the European Union level, because, as you know, the Commission has produced a European care strategy, linking and strengthening long-term care and early childhood and education care. And so there is definitely appetite at the European Union policy level to dig more into this concept of the caring community. So thanks for that. And now we move to another big figurehead in the field of health promotion, and that is Rudiger Krech. He's a director of health promotion in the WHO headquarters in Geneva, and he was responsible also for the latest global health promotion conference that produced this Wellbeing Charter that already Ilona alluded to. Rudiger, the floor is yours to talk about that.
Yeah. Thank you so much, Caroline. So listening to you, this is really good news, right? Because we know so much. I have another good news. I have the bottle opener. And without this bottle opener, there could be as many bottles there, we couldn't drink it. And that is so, let me hand this over to you. And that's very much what health promotion is all about, right? So we need to think things through to see whether or not people can actually have these conducive environments. So let me tell you a little story. When Dr. Tedros, our Director General, called me in late autumn last year, he said, well, if I'm going to be re-elected, what should be my priorities? And I tend to think that we need to have health promotion as the top priority. So, and of course, me as Director for Health Promotion, I was delighted, right? But then also, we looked at the risks. We said we need to have a proper SWOT analysis, our strengths, our weaknesses, the opportunities, and also our threats. And we did this carefully, and then Tedros still decided to say, health promotion must be my top priority. He has other two priorities identified in the technical areas. One is that, of course, we need to get much, much better in preparedness. And the third one being that, indeed, we need a drastic reorientation of the health systems. So the critical question he asked me was, how is health promotion contributing to those other two priorities. So let me give you just very quickly some examples of this. Just looking at what you were saying about health literacy. Just imagine for the next pandemic, we would invest the same amount in producing vaccines, in at the same time have health literacy programs for people to really increase knowledge about what is a vaccine, how is it produced, what are the risks, but what are also the benefits. And to do this in an evidence-based manner so that people can take their informed decisions. Just imagine we would have done this time. I'm sure that the compliance rate for vaccination would have been much higher. Just imagine community engagement. We know the do's and the don'ts in community engagement. Just imagine we would next time be at the table when we're producing those public health measures during a pandemic, that it's co-design, that you need to look at the concrete environment in which we then are, and then adapt a framework of a measure to the concrete environment. That would have, again, increased the compliance rate with those public health measures by so much. Because, of course, at a state level, or even at global level, you cannot see whether in this hotel we would be able to meet the 1.50 meter distances, and how we get to this place, and so on. So to think things through is one of the strengths of health promotion that we learned in the last 35 years. So just linking health promotion to emergency preparedness and response in just the things we already know, that would be great. The second, looking at the reorientation of health systems. Universal health coverage is one of the main goals in public health, right? So, if we were looking at health promotion and how we can contribute to drastically reorient the health sector, this means to look at primary health care, first of all. That means to look at the NCD risk factors, first of all. Then secondly, of course, to then see how we could actually prevent 65% of global disease burden if we did this consistently. If we then also looked at the health sector being environmentally friendly, so having environmental targets, because the waste in hospitals is great. So if then a hospital is also a good employer that pays well, and that actually then is looking at how we can use the shortage of health personnel, so to mitigate that by doing a lot of prevention. That means, concretely, that the reserve funds of any sickness fund, you know, reserve, you need to have 3 months of reserves if you have a sickness fund to keep the machinery going. Those reserves are usually invested on the daily scale in shares, short-term shares. They should not be invested in tobacco. So you need to disinvest from tobacco. You're legally bound to do that if you're party of the Framework Convention of Tobacco Control. A health sector that reorients in this way would therefore also look at their investment practices, right? So looking at how we can contribute to universal health coverage through freeing up a lot of resources through investing into the risk factors like tobacco, alcohol, you know, physical inactivity, sugar, you know, that would be a wonderful way of looking at the universal health coverage goal as well. So I'm just outlining here what innovative health promotion means, and we can go into much more detail because we have so many wonderful experiences where we actually know and work on the instruments that we've started 35 years ago, but of course we need to translate that into today's world.
Thank you so much. Thank you. Thanks for highlighting your 2 points. Health promotion, linking it better to preparedness. And I think this refers also a bit more to the behavioral and cultural insights, units and work that the WHO is getting off the ground. And secondly, to demonstrate much better how investing in prevention will save costs that can then be invested in universal health coverage. Very nice idea, and thank you for launching those. So now we'll have our discussion, and we will be starting the debate with our 2 young Gasteyners, who will give very briefly their take on it. And I would like to start to give the floor to Emel Jorgansi. You are a psychologist, and she is working in palliative care. So the floor is yours, very briefly.
Thank you so much. My name is Amal, and I'm from Cicely Saunders Institute, King's College London. And I guess my main question is, how can we ensure that while we're promoting health for healthy individuals, we make sure that it's equitable and inclusive of those that have serious health conditions, and they also are included in maintaining their well-being? And what are the key policies that could enable that?
Thank you. So you can think already about it. Secondly, I want to give the floor to Torgin Isse, and you are a public health specialist. Torgin.
Hello, my name is Torgin, and I'm a participant of Pan-European Leadership Academy at WHO. As a public health specialist, I think that to create caring community, not only healthcare workers, but the community should promote health. So I'll give you one example from my country. An initiative group of volunteers consists of multiple specialists from diverse areas. They created a page on social media, and they were busting the myths about COVID and vaccination. And this example shows us that using social media, we can promote health. Thank you.
Thank you for that. And you're also watching the Slido questions.
Sure, yeah.
Are there already some questions that are popping up from our online participants?
Yes, we do have several questions. So the first question will be about the investments for health. So what are the, investments for health have different implications for allocating budgets. So how to secure coherence and expedience?
Okay. Thank you for that. I would now like to open the floor to you. We have microphones available, and the questions that you have for our panelists or comments you would like to make on the future of health promotion, on how we can work better together, and on how we can invest more in the future that we want for well-being. Who would like to take the floor? Yes, there, at the very back. If you can also state your name and your organization, please.
My name is Clemens Siegel from the Austrian Health Insurance Fund, and I just want to ask a question, or maybe you can share some experiences about the common problem of some initiatives in health promotion, especially in regional communities. When the funding ends, a lot of times also the project and initiatives ends, and how to tackle this problem, or how to long-term establish initiatives, because a lot of times people are at the end of the project are not used to how to go along without all the funding or all the support of the project.
Thank you for that. Is there any other question? I'll go back to you for a second round. Yes, please.
Thank you very much. Nick Goldemont from the Netherlands. I raised a question about budget allocation. So in the last, let's say, 10, 15 years, there was a discussion on the business case, financial case for prevention, health promotion, which was very obvious. But political, it was very difficult to secure appropriate budgets in many countries, including the Netherlands. So if we're now saying health promotion, prevention for health, or investment for health, rather than investment in health, supposedly it makes the discussion about how to allocate budgets across different sectors more difficult. because it's not more allocated in one budget, which you can control and allocate, but you are dependent on the sort of reliance and compliance from other policy actors in the system. So supposedly it makes it more complex. So it was already complex in the last 15 years. So how do we secure in this sort of logic the budgets, the coherence and expedience?
Thanks for that question. So we have a couple of questions from the audience. Let's maybe take the first one on the budgets and how to get that organized so that we have more investment for health through other sector budgets. Is that, yeah, would you like to go first, Rüge, and then Juka, yeah?
Thank you, because I think we have a real misunderstanding here. Investment for health means to use also the fiscal measures that we have at hand, which are taxes, subsidies, and investments, right? These are the three major instruments that we have in fiscal policies, right? So what we're talking about here is that whole sectors would reorient their investments towards health, to look at this to produce better health. What does this mean? So, for instance, if you see that you know, about 76 countries at the moment are reviewing their health tax on sugar-sweetened beverages. Right? So what is, number one, the fiscal space that you're increasing? On the other hand, what are the commercial interests, of course, of Coca-Cola and companies to actually make their monies? So, in real terms, a can of Coke should cost $4.99 and not 85 cents. A package of cigarettes needs to cost 23 euros. And a Big Mac at McDonald's needs to cost $8. That is the real price if you factor in the costs that it occurs for the environment, but also for health. And that is a real thing that we need to come up with. Now, it's not about healthcare budgets. It's about health budgets. It's about using the economy, using the regulatory mechanisms that we have to regulate so that it's not that profits are individualized and the costs are socialized. That needs to change. And therefore, you need to invest. That's the current thing that you would need to do. So at the moment, of course, then it's not just ministries of health. It's ministries of finance. It's the trade that need to be involved in this discussion and making those healthy choices, right? So that is what it's about. And just to say also about this projectitis, you know, we're living from one health promotion project to the next, but what is this? If a project is there, it's about to prove concept. And if the concept has been proven, it needs to be mainstreamed. It needs to be available to all, right? So that is the current thinking that comes back from the early days of health promotion. With that, we will not actually address the major societal crisis that we have. This pandemic has cost trillions. And it would have been preventable if health promotion was there. So this cannot be a matter of, you know, a little $10,000 here and there. No, it needs to be mainstream. And that is what ministries of finance are very much waking up for.
Thanks for that. And yeah, I think it's an applause. how with fiscal policy we can make those changes and how we need to work better with finance people and understand also the finance sector. It's not so easy to understand for public health people, and it's important to get that understanding and see indeed how with taxation we can tax the bad and subsidize the good for health and the planet. That's a real good strategy forward. Duke, you also wanted to come in on the investment, and you also have your cliffhanger.
Yes, yes. Yes, that's the reason why I took the microphone. But it is about finance, and it is about a system change, and I want to share in the Netherlands, because of the COVID, we see some movement. There is more possible for the health promotion. And what we see, that was all earlier, we see more like intervention in the care, like combined lifestyle intervention, also social prescribing, are part of our basic health insurance package. That is a huge movement, because now prevention is for a part financed by the health insurance package. But on the other hand, what we are now going to do is, before this year, we are working in silos of, we have separate programs. We have programs for health inequalities, for overweight, for alcohol, for smoking, for healthy environment. And after COVID, the ministry decided to change the law, which is not a success yet, but to change also the finance. So we have all, before we had all budgets for all these programs. Now the budget is combined. So social prescribing and healthy environmental, health inequalities, but also sports are combined, all these and the budget is going to the municipalities, and they have to make integrated plans to intersectoral collaboration for these topics. I'm not sure it is successful, but I think it is one step ahead, because you can combine the money and you have to use the data. Is this important for us? Is this an important problem for us? But we need to collaborate with other sectors to be successful. And well, it is a step, it is not everything, I think, but well, also the other ministries are involved in this budget. So I want to tell you about 3-4 years ahead, what is the success of this kind of change. That's just a practical example.
Yes, very, very nice, because having common joint budgets, it brings people together, no? Already the fact that there is the money available allows them maybe to work better together and see the commonalities. Very promising, nice. So we have a few questions outstanding. Also, the question from our young Steiner about health promotion, is it good for including for people that are already ill or have health problems? You know, how can it be inclusive? That it is not only like well-being for the ones that are healthy already, and very much the always risk that we have in health promotion, that we unintentionally widen the gap of health inequality. So that question is there, and about the projects base, I don't know whether, Margaret, whether you want to say something about that?
Yeah, just a quick reaction on that. I mean, you're absolutely right. I mean, the pattern up to now has been, you know, let's invest in a pilot initiative, give it a couple of years, put in the research, and, you know, and then maybe move on to another one, to something else that's new. The examples of where we've seen initiatives mainstreamed, it has taken at least about 10 years, which is too long for that to happen. So I think that process needs to be massively speeded up. And we also need to see, I think, the generation of evidence for implementation, actually. You know, you've got the evidence regarding, yes, the outcomes are effective, but you need also the research around the how. How will this work at the local level? And that, you know, we need building up that base. To come to the question about the inclusiveness, which is, of course, the fundamental principle of health promotion. And health promotion works at the population level, but it isn't just for healthy people. Health can be promoted across the board. And also we can see from the evidence that, in fact, health promotion has the biggest impact for those who are most at risk, actually. Yeah? and that they're, so it works at that level as well, and that is really quite important. And also community initiatives often work with people who are most disadvantaged and most excluded, and come to bring them into being more central within communities, so that bridging social capital piece. So this is fundamental to what health, the equity impact must never be lost sight of.
Yes, exactly. Thank you. I would like to see if there's one more comment or question you would like to ask. This is your final moments. Yes. Please, if there's a microphone for the lady in the front. And if there's anyone else.
Yeah, thank you so much. Actually, most of the things that I wanted to comment on have already been said. My name is Andrea Schmidt. I'm the head of the Competence Center for Climate and Health in the Austrian National Public Health Institute. I wanted to, first I wanted to just say, allow me one sentence on also the importance of the health sector for fighting climate change, which Rüdiger mentioned, but just also to kind of not only say that it doesn't work only in that direction, but also in the other direction, so that actually the health sector has a responsibility also in becoming more climate friendly. So I'm very happy that Austria has been brave enough to tackle this challenge. And also I wanted to say that because it was said in the intervention from the lady from the World Bank that it's mainly young people in the climate movement. And I would like to challenge that as well, because I think everyone in this room, also those born after 1986, have a role to play, and I do believe that we shouldn't also think that it's just a movement of young people. Now, my question. So I wanted to ask, who are the professions, in your opinion? So we had a large panel on the health workforce yesterday. And so what professions do we actually need to get to this, as it was called, a transformative communities, or what is the role? Are these medical doctors? Are these social prescribers, agents, or are these other professions? Thank you.
Thank you. Very nice question. Yes, Melanie.
Thank you very much. Excellent session. Mihai Kökei from Hungary. So let me continue the convincing statement by Rüdiger on the need of cooperating between staff of health and finance ministries. So my question is, do you think it is enough? Shouldn't we move further and discover the sometimes dirty world of politics and approach top policymakers, parliamentarians, and so on? So let me be frank, a couple of them may be dependent on industries in terms of financing their re-election campaign. We have to be sure about these things. We need to work for more accountability, transparency, for having regulations and laws on these things to make your dream true. Thank you.
Thank you for that. I would like to give all five of you one more opportunity to speak and take those two questions into account. So one is on the workforce for health promotion, and it's very fragmented, but the health promotion community is there, and many more people are doing health promotion without them knowing. And secondly, on the issue of politics. It's so much linked to politics, and are we active enough on the political determinants of health? And well, I thought I'll start with you, and then I'll go to the very end. Yes.
So I suppose final statement. I think we need to invest in what works. We have a lot of information, but we need to really see investment in cost-effective approaches that will make a significant difference. And we also need to build the capacity to deliver on that and to mainstream. I think this is that actually we need to invest in resourcing the scaling up of what works. Leave it at that. Yeah.
Thank you. Juka?
With respect to the professionals, I think we need linking agents, and we need, well, of course, health promotion specialists. But especially linking age who are capable to make the connections between the healthcare, environmental care, and also the health promotion. So that it's not, I think a lot of professional can be, but it is the role, what we need. We need people with expertise, but we need the capability to connect all these sectors. That's what I'm...
Thank you. So maybe thinking through the professions, because also these statements were for sort of the tips and the recommendations and advice from the panelists for the development of the 3 competency centers that are now being set up. So, yes.
Yeah, I also want to add one thought on this question, whom do we need? I think a well-balanced mixture of engaged citizens and professionals out of all sectors, and mainly professionals who have a kind of self-understanding of enablers, of connectors, of bringing different worlds together in best case. And therefore we would need, I think so, new spaces on a very local level, but also in a kind of intermediate level to bring together these different resources. And one final thought in listening here, this panel, I think we can very well build on this transformational energy and passion of societal movements in care contexts and other contexts we've heard. And I think to enable them to bring this in practice, we need this kind of new governance structures we discussed, yeah, and that would be the next step.
Thank you. Miriam?
Yeah, I also agree that we really need to scale up and to mainstream the relevant initiatives and relevant actions. And I also totally agree with you that it's not only young people who have a particular role in play, but every one of us. So, yeah.
Mm-hmm. Yes, okay. I'll first go to Rudiger and then back to you, Duke. Rudiger, yes?
Yeah. First of all, what sort of expertise do we need in doing this? I think we have a huge experience in this work, which we called Health in All Policies, where we look at what sort of skills, competencies do we need in the health system overall, and what it needs. Of course, there's a role for social science, of course. But then what sort of skills do we need? We need to listen to the agendas of the others. We need to understand what is the role of the housing sector, the transport sector, or the banking sector, right? And then make propositions that are useful to them and useful for health. That is, I think, the learning that we have, and also the skills, therefore, to mediate an issue of the Ottawa Charter. Empower, mediate, advocate. So these are still the skills and competencies that we need in health promotion, that we need to improve, of course, and translate into today's world. But that's what we need there. Mihaly, yes, of course, it's politics. Of course. Let me give you one example. So there's this World Health Summit in Berlin, an important event that you all need to follow online or be in person. But there we're going to launch a consortium for tobacco cessation. You know that 400 million smokers want to quit, and during COVID it was actually even an estimated 200 more million smokers. So this huge number of smokers who really want to quit smoking. And then the tobacco industry says, oh, go and have e-cigarettes or vape. That's a cessation device. And of course we know that this is all fake. It's not true. So we're having a consortium with the social media, Facebook, Viber, TikTok, together with those pharmaceutical companies who have these nicotine reduction devices, or medicines, and of course the health insurance funds. So all of those have a different interest, a commercial interest, which is different from that of the tobacco industry. So when we're talking about health in all, or we used to talk health in all policies, and commercial determinants, we need to work within those politics to understand there's different commercial interests that might actually balance themselves out. So if we then have social media campaigns that put the truth up front about all the risks with e-cigarettes and vaping, that this is not a cessation device, but on the contrary, to offer, not only apps, but things, the environments, digital environments in which I get the help when I have this need to smoke. Mm-hmm. Right? That is a new way of thinking on commercial determinants and politics, and I think that's the way we need to go.
Yes, thanks for that. And I do think that the commercial determinants and politics all also is brought together by the economy of well-being principle that we discussed earlier today in another session, and these are vital to address for us in the future, vital questions for your competency centers. Jukka, you wanted to briefly take the floor because I also would like
I had to end with one sentence,
yes.
And what we need is use data, evidence-based practices, and this moment of momentum of post-COVID to keep or to put on health promotion, intersectoral collaboration on the political agenda, and also to influence the political will to change, to make some slight changes in the system. That was my take-out message.
Yeah, good. We have to keep going. Okay, thanks to all of you. I would now like to invite Ilona to take the floor for a wrap-up and your reflections on the debate so far.
Thanks very much, Carolyn. Thank you very much to the panel. And I just want to let you know I was rushing around a little bit earlier because I had left my iPhone somewhere. And I actually got it again. So I'm a complete human being. Yes, but that's why there was some unrest. I just want to highlight a couple of things that I find particularly important. And one is this tension that we do have in health promotion. We want to be transformative. We want to contribute to big changes, whatever we call them, investment for health, caring communities, whatever. At the same time, we have a responsibility towards people here and now. And we have particular responsibilities, as this question over there by one of the young Steiners put forward, towards the most vulnerable. And to balance that, I think, is a tremendous responsibility, because we don't, I'm not going to go into a discussion about how we define resilience, but the issue is, no, we don't want things to remain as they are, but we have to be useful to people where they are. And whatever words we use for it, I think that is the important thing. And there, your message is so important, where we do have outcomes and we do have research and we can show this works. There we need to have the strength and the support of communities, of politicians, of parliamentarians to take it to scale and to find new ways of financing it, either close to the health system or elsewhere. And yes, it was a big step forward when in Germany, for example, prevention became part of the responsibility of the health insurance. It was a revolution at the time, but we saw it was not as transformative as we had hoped it would be. And we're still fighting for it. And if you look at the development, some of the German speakers here will know of this concept of a Gesundheitskiosk, of a walk-in clinic in a way where people, particularly vulnerable people in communities, can go to. It just doesn't move forward because entrenched interests, not even in society overall, entrenched interests in fossilized health systems will not allow change. And I think this, this reorienting health systems continues to be an enormous challenge because actually health professionals, doctors, health insurers, etc., should be the supporters of this transformation. But they are not. And I hope that we can also, to some extent, discuss this more openly, maybe next year in Gastein, what this means. The second thing I just want to raise relates to some of these, in quotes, financial discussions we've had. We always talk about finance ministers. I'm actually interested, and again, I take the example from Germany. We actually have two ministers. We have a finance minister and we have a minister for the economy. And the minister for the economy in Germany actually has a department that is called Gesundheitswirtschaft, the health economy. And I think if we are discussing around investment for health, we have to become much more astute, first of all, in how we define that health economy, how we define profit-making within that economy. And the health economy is becoming more and more and more important for all countries. And it's a major global economy. And unless we look carefully who profits, who benefits, where is there real investment for health, and where is it, you just need to take diabetes. You go to a health promotion conference and you hear all about, you're depressed when you leave, when you hear about how diabetes goes up, and you go next door to the economic conference and you hear how much the growth of diabetes contributes to the growth of the gross national product. So I think we need to be more astute here in terms of sort of macroeconomics, but to some extent then also microeconomics if we talk about the local. And that's my very last point. Yes, we do need local action. In many cases, this health in all policies is easier. We ran a major project in South Australia on health in all policies, which was all about co-benefits and putting a health lens on policies, as we said. And our first major success was when we went to one of the council meetings and they were discussing a housing project, and one parliamentarian raised her hand and said, "What does that mean for health?" And I think that is what we want. And there you are totally correct. For that, we need connectors. Health promotion are people, in German we say, man muss sich den Mund fusselig reden, ja. Health promotion people are people who connect, who have to be able to talk, who have to be able to convince, but have the evidence and the data at their hand. And this is what we need to work on, and then maybe we can take it to scale. Thank you very much.
Okay, I would like to thank Ilona for your final words, very insightful as ever. I would like to thank Judith for your vision for the health promotion agenda in Austria. I would like to thank all of the speakers, really great, well done, Margaret, Juke, Klaus, Miriam and Rudiger, and our two young Gasteiners. Thanks for all of you here asking your questions, and also thank you for the online participants. Thank you.